very low level during the daytime, and particularly during the night time there is surge of growth hormone. That's why preferably growth hormone, recombinant growth hormone should be given during the night time subcutaneously. Side by side, it is very difficult to get the level of the growth hormone, because sometimes you may get the growth hormone normal, or sometimes you may get the growth hormone abnormal, because particularly in the growth hormone you have to do the stimulation test, either by clonidine or by arginine or by insulin, but these are very difficult. So that's why what Dr. Shetty has told, that growth hormone will not act directly. It will act on the growth hormone receptor which is present in the liver, and they will produce the insulin-like growth factor 1, and that will bind to the insulin-like growth factor binding protein C. That IGF-BP3 is very important. So that's why it is better to do the IGF-1, and most important is IGF-BP3. Those who are malnourished, they have a low level of the IGF-1. That's why the most important is IGF-BP3 for detection of the growth hormone deficiency. Another important thing Dr. Shetty has told, that there were some patients who are not responding to the growth hormone. These are the patients who have a growth hormone receptor defect. So growth hormone level is normal, you are giving growth hormone 1 centimeter per year, there is improvement. So what you should give? Next, that is IGF-1 you should give. And for your information, IGF-1 is also available in the market. So we have advanced so much. Those who are not responding to the growth hormone, particularly what he has told, Laron syndrome, where is a growth hormone receptor problem, then you can add the IGF-1. Third important regarding the growth hormone, it is very difficult for a child to give everyday injection, because you have to take at least for around 8 years or 10 years up to the age of puberty, when the epiphysis has joined with the metaphysis, or we have achieved the mid-parental height. So it is very difficult to give the injections daily. That's why at present the growth hormone long acting, that is pegylated growth hormone, is also available, and it has to be given twice in a month. So these are the latest development. One is pegylated growth hormone twice in a month, and another is IGF-1 is available not in our, but in America it is available. It has come in the book. Third important, I have started this growth hormone for Turner syndrome for one patient, and I got the good reputation from every angle. But the most basic thing is, in case of Turner syndrome, there is no deficiency of growth hormone. That is most important. In case of Turner syndrome, that is XO, there is no deficiency of growth hormone. Then how does it act? Very difficult to say. But it is seen that if we give the growth hormone plus oxandrolone, then at least we can achieve 10 centimeter height from what will be in the normal Turner syndrome around 140. But if we give the growth hormone plus oxandrolone, then we will achieve around 10 to 10.5 centimeter. In our case also, I have got achievement around 9.8 like that. So these are regarding the another important, how you monitor the growth hormone. This two important what Dr. Shetty has told, that one is the height, another is IGF-1, and most important is IGF-BP3. At least 6 months interval we should do, and we have to keep the IGF-1 and IGF-BP3 within normal level. If the IGF-BP3 is more than 2 standard deviation, then we have to reduce the dose of the growth hormone. can otherwise there is a chance of this gigantism or acromegaly. So that's why you have to reduce the dose of growth hormone when the IGF PPC level will be more than 2 standard deviation. And what are the indications? Dr. Shetty has already told, mainly for the short stature. Even you can, those who are idiopathic short stature, young children, those who are suffering from chronic renal failure, you should add the growth hormone before renal transplant. It will not only improve the height, but it also improve the bone mineral density, and it will try to modulate the renal osteodystrophy. So that is one of the important indications of growth hormone in case of children. Another latest indication is IUGR, so that is the intrauterine growth retardation, and those maybe who cannot achieve the catch-up growth up to the age of 2 years, you should start the growth hormone. First is that is a different issue. And nowadays it is also seen that in case of this HIV disease, those who are grade 4 malnutrition, you should give the growth hormone. Here also it will help in the particularly the anorexia, vomiting part will be over, and number 2 it will improve the lean body mass, and number 3 it will improve the bone mineral density. And we had one case around 5 to 6 years back of Prader-Willi syndrome, and we presented the case in this API meeting. We planned for growth hormone because in case of Prader-Willi also there is a short stature, obesity, and there will be the hyperglycemia, almond shaped eyes that we have presented in the API. We planned for this growth hormone, but after that there was no follow-up. So we couldn't start. So these are regarding the latest of this.
How many cases you have seen here?
I give, I think, 2 patients only. Dr. Shetty is giving one.
This is one, another
Turner.
Turner syndrome.
Turner
and this one.
Another patient was there who तो lost to follow तो division कर. आधा के विषय